levels, size, shape, then those red blood cells, it's not nice for them to survive. The body doesn't know them. So these macrophages within these organs, called the reticuloendothelial cells, will engulf such useless red cells and make sure that they are destroyed within those organs. This is what we call extravascular hemolysis. It's normally not massive as compared to, in any case, you have more red cells in the blood vessels than those in those organs. That alone should tell you that when hemolysis in the blood such, it will be high cells and make sure that they are destroyed within those organs. This is what we call extravascular. Now, you can have red cell sequestration in the case of problems like sickle cell disease. You can have red cell sequestration in normally not cells massive as these organs, that, for example, the spleen within those organs. And there will be blood called extra within the vascular. You can have lead red cell enlargement of the spleen. In the case of, so in most cases, like sickle cell disease are suffering, you can have red cell extravascular. In normally you realize that massive they present with spleen meganucleus organs. And there will be blood. Shape, it assumes a spherical shape. The reticuloendothelial cells don't know to destroy them. Infections, our own malaria, when the parasite enters the red cells, they mature, multiply the number, burst the red cell, only to come into the bloodstream and infect other cells. So the erythrocytic stage will reoccur and be destroying red cells after red cells until you interfere with, will also lead to hemolytic anemia, because it is also hemolysis. So you can have hemolytic anemia in malaria. So let's now try and find out which one is the cause of the hemolysis. Let's try and go after the autoimmune reactions. So if you want to find out that this person's hemolytic anemia is caused by an autoimmune reaction, then you do what we call the direct antibody test. Autoimmune reactions involve antibodies, and therefore we want to find out if antibodies are produced, and antibodies are directed towards the red blood cells, and this is what is causing the anemia. Then we can confirm that it is an autoimmune hemolytic anemia. What you do the Combs test. If the test comes as positive, then you confirm that it is an autoimmune autoimmune hemolysis. If the Combs test comes at positive, then it is due to an autoimmune reaction. If it comes out as negative, then it can never be an autoimmune reaction. It can be other underlying causes. Now, let's take it as positive autoimmune hemolysis. If it is positive, then it means that you are going to find some antibodies. Red blood cells include immunoglobulin G and complement factors. Immunoglobulin G and complement factors. So the Combs test is after immunoglobulin G and complement factors. If even one of them is positive, then it is an auto. Then it is non-autoimmune hemolytic anemia. So you are going after the membrane problems or the infections or the hemoglobinopathies or the enzyme problems. So now we are looking at where there is positive antibody testing, a confirmation of an autoimmune hemolytic anemia. With this, there could be two types. The underlying cause could be two types. It could be either the warm type autoimmune hemolytic anemia or the cold type. Again, we will look at this in detail. But the word warm type is so because normal and high temperatures will always favor the warm type, whilst temperatures below 37 degrees will always favor the cold type. If you do the Combs test and both immunoglobulin G and complement factors are present, if immunoglobulin G and complement factors are both present, then it can only be the warm type of hemolytic autoimmune anemia or autoimmune hemolytic anemias. If only the complement factors are present, but immunoglobulin G is absent, it is still a positive test. It is still a positive test, but this time it is the cold type that is present. So when both factors, immunoglobulin G and complement factors are present, we are referring to the warm type, the one that occurs at normal and higher body temperatures, 37 degrees Celsius and above. If it is only complement factors that are present, then normally you see that it happens at body temperatures lower than 37, and that is termed the cold type. In both situations, we have different ways of managing them. We will look at them very well. Any queries? Any queries before we go to the situation where the autoimmune test is negative? Yeah, hello?
Sir, please, can you reiterate on the Combs test? I didn't get it well. And the importance of it.
All right. So now you are looking at a patient's FBC. You check the hemoglobin and you realize that it is lower than the normal range, as in the lower limit of normal. The hemoglobin is low. So there is anemia. That's a confirmation of anemia. You want to know whether it is a production problem or there is a loss problem. So you do the reticulocyte index, and it is greater than 2%. Obviously, it is not a production problem. It's a loss problem. So if the loss problem, forget about all the problems with production. Focus on the loss. So the losses could also be either you are bleeding or hemolysis is ongoing. How do you know that the retic index greater than 2% here in this patient is a bleeding problem or a loss problem? So now you decided to check for markers of hemolysis. All these things are there. Then it confirms that there is hemolysis. So now you are forgetting about blood loss, that is bleeding. You are forgetting about bleeding because you have markers showing positive hemolysis. The hemolysis too can be caused by so many things. One of them is autoimmune reactions. That is autoimmune hemolytic anemia. Another one is non-autoimmune causes, and this may include red cell issues like hemoglobinopathy, sickle cell disease. It could also be red cell membrane enzyme dysfunction, glucose 6-phosphate dehydrogenase deficiency. It could be red cell membrane problems like the shape, spherocytosis. Instead of the cell being biconcave, it is now spherical. No, this is not acceptable. It could be even infections within the body, our own malaria. So you have excessive amount of red cells being infected with malaria parasite like the P. falciparum, and they will grow, destroy the red cells, enter another red cell, and if you don't interfere with the cause of the disease, you will end up losing more and more red cells. That is hemolysis. Our problem now, we don't know which one is there. All we know is there is hemolysis because the markers for hemolysis are positive. Now let's go after them, the various causes, to be able to identify which one is there. So let's say we are going after the possibility of autoimmune cause. If that is what you are after, then the lab that you want or you have to do is the so-called Coombs test. What is Coombs test? A test that identifies antibodies directed towards red cells, and the antibodies will make sure that the red cells are destroyed. What are these antibodies? Immunoglobulin J and or complement factors. So if you do the Coombs test, also known as the direct antibody test, and it comes out as positive. Positive means you can have either complement factors or immunoglobulin G or both being present. Now, in a situation where both are present, we term that type the warm type autoimmune hemolytic anemia. When both immunoglobulin G and complement factors are positive, that one is termed the warm type autoimmune hemolytic anemia. And I'm saying that you realize that in most cases at normal body temperatures or higher body temperatures. If it is the cold type, you realize that normally it happens when the patient's body temperature degrees, and the Coombs test will only show positive for complement factors. It's not immunoglobulin G. If this happens, you term it as the cold type autoimmune hemolytic anemia. You need to determine this because the approach, the strategy for their management differs so that you know how to go about it. In some of them, you may use steroids. Others, steroids are contraindicated. So the treatment approach is different, and therefore there's a need to differentiate. That is why we are worrying ourselves to do these distinctions. Please, are you okay?
Yes, sir. All correct, sir.
All right. Thank you, sir. All right. Now, if you do the Coombs test and you don't get either immunoglobulin G or its counterpart, complement factors, then it means that there is hemolysis, but it cannot be an autoimmune induced. So negative Coombs test, but positive hemolysis means that it is not an autoimmune induced. And therefore, you are going to look after the non-autoimmune causes of hemolytic anemias. What are the possibilities? One, it could be due to a problem associated with the red blood cell itself. There's a problem with the red blood cells where the body is rejecting the red blood cell. Or it could be a problem such that the red blood cell, they are perfect, but other problems, not the fault of the red cells, are leading to the hemolysis. So now let's look at the situations where the problem is with the red cells themselves. The red cells themselves, the problem is there. What are the possibilities? If the problem is with the red cell, you term it as an intrinsic hemolytic anemia. Intrinsic, it is with the red cell. Intrinsic. Extrinsic, the hemolysis is happening, but the problem is not from the red cell. It is some other cause that the red cells are suffering. It is not a problem with the red cell. So what are the intrinsic causes? As I've been saying, it could be number one, some enzymes that are associated with the red cells. So we all know that red cell membrane has an enzyme called glucose-6-phosphate dehydrogenase. And briefly, it helps fight against oxidative stress. If you don't have an intact glucose-6-phosphate dehydrogenase and you are exposed to oxidants, then you can't neutralize the oxidant, and the oxidant will oxidize your red cell membrane, leading to hemolysis. So if you have an enzyme problem, red cell enzyme problem like glucose-6-phosphate dehydrogenase deficiency, G6PD, it means that you are unable to fight the presence of oxidants. It means the red cells is going to be destroyed. In this case, normally, if you do a peripheral blood smear, you realize that the red cells are presenting with cells called Hens bodies. Hens bodies. So your red cells will appear as Hens bodies. What are Hens bodies? Those who know football bodies. Hens bodies are red blood cells with damaged hemoglobin, and this is due to oxidative stress. So it means you don't have the G6PD, you can't fight any oxidation. One of the problems is your red cells having hemoglobin oxidized. Such red cells are called Hens bodies. Hens bodies will be seen as useless. Your body doesn't know red cells with damaged hemoglobin, and therefore they must be dealt with. If you don't have any proper role to play, we will cut your life short. And therefore, the cells of the reticuloendothelial system will have to deal with them. As part of the process of the destruction, the way when you are chewing biscuit, the flat biscuit, you normally, boys will put everything in their mouth. But girls, they will have to flex a bit. So there will be a bite. So they will bite it, and then it will create some mark there. So some shape that is bitten off. So you have the whole circumference not being intact. Some aspect of the circumference is bitten off. Boys, we put the whole biscuit in our mouth. Girls will bite it bit by bit. So these hen cells, when they bite or when they are bitten by the macrophages, then they appear as bite cells. Bite cells. Class captain, can you confirm the picture I'm trying to create for bite cells? Anybody confirm? You can confirm, right? All right. Yes. So when Hens bodies, which are useless, red cells with damaged hemoglobin, they are bitten by the macrophages, then we call them bite cells. So you are going to observe such cells in a peripheral blood smear under the microscope if it is G6PD. So you will see Hens bodies, you will see bite cells. The moment you see this on peripheral blood smear, suspect glucose-6-phosphate dehydrogenase deficiency. Because by that time you already know that there is hemolysis positive. You know that Combs test is negative. And on the peripheral blood smear, you are seeing Hens bodies and bite cells. Suspect glucose-6-phosphate dehydrogenase. What do you do? Confirm the enzyme activity, whether it is partial or full defect. This is how come we confirm that this G6PD or not. Now, another intrinsic problem could be hemoglobinopathy, a problem with the hemoglobin. Typical example is sickle cell disease. Sickle cell disease where you produce some useless hemoglobin that upon exposure to low oxygen dimerize, and it will make the whole red cell change shape to half moon, also known as crescent shape. And the red cell will lose its flexibility and become rigid. A rigid crescent shape destroyed hemoglobin red cell is as useless as anything, and the cells of the endothelial system will deal with that, and therefore you are going to have excessive hemolysis by the reticular endothelial system. This occurs as a result of just a point mutation amino acids in the beta chain of the hemoglobin. There is a problem. Position 6, valine replaces glutamine. Just a point mutation gives rise to this hemoglobinopathy called sickle cell disease, and that will change the hemoglobin. It will polymerize upon exposure to low oxygen tension. The red cell will change from the biconcave shape to crescent shape, also known as the sickle shape, and its flexibility that enables it to meander its way through microvessels will be lost. The red cell becomes rigid. It blocks blood vessels, giving rise to so many complications. Such red cells must be dealt with, and they will be destroyed. So they will be hemolyzed by the cells of the reticular endothelial system, leading to anemia. There could also be membrane problems. Red cells are supposed to be biconcave, not spherical. If they are spherical, one critical thing that we see is that when we subject them to osmotic fragility tests, so we create an osmotic gradient such that more fluid can enter the red cell. The red cell membrane, when it is spherical in shape, is fragile. So the slightest water that enters, the red cell breaks down.
Hello.
This happens. Yeah, hello.
Please, I got this disconnected, so I didn't get the hands, bodies, that part.
Oh, okay. So we are saying that if you have G6PDD, that is glucosase phosphate dehydrogenase, you are not in a position to counter oxidative stress, exposed to oxidant, anything that can create oxidation like fava beans, sulfur-containing drugs, the cinchona alkaloids. What have you? What happens is that the oxidative stress can hemolyze your red cell membrane and even the hemoglobin. So on peripheral blood smear, you observe red blood cells that their hemoglobin has been damaged. Such red cells are called Hens bodies. Red blood cells with damaged hemoglobin, clumps of damaged hemoglobin as a result of oxidative stress are referred to as Hens bodies. Now, your body doesn't know any Hens bodies. So Hens bodies are considered as foreign, and for that matter, they must be destroyed by the reticular endothelial system, which is within the spleen, the bone marrow, and the liver. So they will attack. They will just be in these organs. Anytime that any blood containing Hens bodies get to these organs, the macrophages in these organs will engulf or act on these Hens bodies and bite them. So it will appear like when you, as a lady, you are taking your biscuit, you don't put everything in your mouth. You take a bite and it will create that shape, the circumference, you bite into it. So on the peripheral blood smear, there will be the presence of both and the hemoglobin, hence the presence of Hens bodies and bite cells. What do? Test the enzyme, confirm the presence of G6PDD by testing the enzyme function. So you do the what? The enzyme activity test. You can get either full defect or partial defect in females because it's what? An X-linked condition. It's a recessive X-linked condition. So in females where you have both XX, you can have either only one of them being affected, and that will create partial defects. If you are not lucky and both are affected, then you get full defect. This means that in males, we are so unlucky. You only have one X, If it's an X-linked recessive problem and our only X is affected, then we males can only have full defect. So with G6PD, males can only have full defect. There is no partial defect for males. So G6PDD with males, it is only full defect that we can get. So to us, it is all or none, whether we have full defect or no defect. But to females, since they have 2X, and the condition is an X-linked recessive problem, it could happen that only one of their X is affected. In this case, you have a partial defect in females. If they are so unlucky and both X's are affected, then they will also get full defect. So females, G6PD, can have two phenotypes, either partial or full defect. Unfortunately, for males, we can only get full defect or nothing. Please, are we okay? In this case, the solution is to get away from oxidants. Move away from oxidants. Don't get close to oxidants. If we say don't take fava beans, don't take it. Don't take sulfur-containing drugs. Don't go there. If you go there, the enhanced bodies will be produced and you face trouble. Please, are you okay? The one who asked the question.
Yes, please. Thank you.
All right. What says the time? Class captain, when it gets to 3:50, let me know. Class captain, please, are you there?
Yes, sir.
Okay.
Yes.
Now, let's go to the membrane problem. And we are saying that if you are a red blood cell, you better come with biconcave and you appear spherical. You want to be perfect. The reticular endothelial system will deal with you because that system doesn't know any spherical red blood cell. Never. You should come as what? A biconcave. So in some situations like hereditary spherocytosis, as the name even suggests, hereditary spherocytosis, most of the red blood cells appear spherical in nature. And one thing that can be seen with these red cells with spherical shape is that they are fragile. There's a slide up for such spherical red cells. They always fail the osmotic fragility test. You will see that you are undergoing hemolysis all the time because your red cells are spherical and the body doesn't know any spherical red cells. So with hereditary spherocytosis, hemolysis can occur. It's a problem with the membrane of the red blood cell, the shape, instead of it coming as spherical in nature. Then we can also have a second aspect of the membrane problems, paroxysmal nocturnal hemoglobinuria. In this case, you realize that the patient presents with clot or have a history of clot. On peripheral blood smear, again, there are spherocytes. And typical of these individuals, their early morning urine are typically dark. And they always show positive tests for flow cytometry. So for flow cytometry, the hematologist will do it. And if it's positive, they will say that you are positive. But looking at the name, paroxysmal nocturnal hemoglobin, so it means that the hemolysis occurs at night. And therefore, your early morning urine is going to appear Coca-Cola-like. On peripheral blood smear, you again have spherocyte. So the distinction between the hereditary spherocytosis and this one is that in both scenarios, there will be spherocyte. But in the nocturnal issues, there is early morning Coca-Cola-like urine. And the person hemoglobinuria. The common thing with both is the presence of spherocytes. The distinction is that with the hereditary spherocytosis, of course, it will lose the fragility test. In addition to this, the paroxysmal one, the patient will have a history. So history is always important. Drug history, medical history, social history, very, very important as part of diagnosis. So a history of venous clots from the patient and the presence of early morning dark-colored urine indicates the presence of paroxysmal nocturnal hemoglobinuria as a non-autoimmune hemolytic membrane problem, an intrinsic factor. Class captain, are we okay? These are all possibilities of hemolytic anemias. As always, you need to draw your conclusion. Dive deep before you start your treatment. Let's continue. As part of the non-autoimmune ones, we said we have intrinsic. Intrinsic means the problem is with the red cell itself. Then where the problem is not coming from the red cell, the problem is not any of these. The red cell doesn't have any enzyme problem. We don't have any hemoglobinopathy. We don't have any membrane problem. And the Combs test is negative, yet there is hemolysis. Then we classify that possible cause as extrinsic hemolytic anemias. It could be due to either infections or a combination of several pathologies together called the microangiopathic hemolytic anemias. So the extrinsic non-autoimmune hemolytic anemias could be either a MAHA issue. MAHA means one of the problems that give rise to microangiopathic hemolytic anemias, or an infection. Now, let's look at the MAHEs. So typical of MAHEs, those who have worked in the ICU, I'm not going to ask you questions, so please don't panic. In the ICU, we normally have a lot of MAHEs, be it HELP syndrome, as per the ONG cases, be it hemolytic uremic syndrome, be it thrombocytopenia, where you guys have been dealing with a drug called L-thrombopag-olamin. Those who have been to the ICU, you have this encounter. When this happens, the anemia that occurs is classified under the microangiopathic hemolytic anemia. Typical characteristics is the red cells being low. Of course, there is anemia. With thrombocytopenia, so low red cell count, with low platelet count. And one other striking thing is that the red cells that are present normally appeared shattered, blasted. It's like we've thrown a bomb at those red blood cells. So shattered red blood cells on peripheral blood smear. So when you have low RBCs with thrombocytopenia and on peripheral blood smear, you see shattered red blood cells and markers of hemolysis present. Suspect any of the microangiopathic hemolytic anemias. What and what can lead to a MAHA? DIC, disseminated intravascular coagulation, can lead to a MAHA. So in situations of sepsis or any critical illness.
Please, I'm lost. Can you go over?
Okay. So we are trying to explain the extrinsic non-autoimmune cause of hemolysis. Extrinsic, that means that the problem is not like a problem with the red cell. The red cell is perfect. There is no issue with its enzyme or its membrane or its hemoglobin. There is nothing wrong. Yet, factors or issues from elsewhere is resulting in the hemolysis. That's what we say is an extrinsic hemolytic anemia, a non-autoimmune cause. Two main issues can result in extrinsic hemolytic anemias. It's either a microangiopathic hemolytic anemia or an infection. So, extrinsic hemolytic anemia can be caused by either a MAHA or an infection. Let's look at what goes into MAHA, the types or the factors that can contribute or lead to MAHA. So, when you say MAHA, the characteristics that are striking here is that it comes with low RBCs, with thrombocytopenia. Every MAHA, all the types that we are yet to discuss, be it DIC, be it HELP syndrome, be it hemolytic uremic syndrome or whatever, these things are common. The common thing is that you will see low RBC with thrombocytopenia. And on peripheral blood smear under the microscope, you are going to see shattered red blood cells. Red blood cells that appears like they've been bombed at it. So red cells are at it. You are going to see them under the peripheral blood smear, as in under the microscope, with thrombocytopenia, low platelets, and low RBCs. So what are examples of the situations that can lead to MAHA, that is microangiopathic hemolytic anemia? What are some of the situations? And we are talking about, or we are citing, disseminated intravascular coagulation. This can happen in critical illness, when the patient is critically ill and the patient qualifies for ICU care. You can get disseminated intravascular coagulation, where the person has reduced, as in hematopoietic parameters, or increase, such that the person is prone to bleeding. So prothrombin time is very high. All the markers not bleed are getting this, and the patient is bleeding or is at high risk of bleeding. That is what we call disseminated intravascular coagulation. It occurs in critical illness. Everything can't be controlled. So critical illness or sepsis, when you have infections of the bloodstream, it can even lead to septic shock. In these situations, a microangiopathic hemolytic anemia, where there will be low RBCs with low platelets and shattered red blood cells. These shattered red blood cells are called schizocytes. Schizocytes, shattered red blood cells. You will see it under the microscope when you do a peripheral blood smear. So in DIC, you will see it in conditions like sepsis or any critical illness that demand ICU care. And typical in DIC, you are going to have the patient being at risk of bleeding. And for that matter, if you do the hematology, you have INR being high, you have prothrombin time, or prothrombin being high, prothrombin time being low. So all the things that point towards the person likely to bleed will show in disseminated intravascular coagulation, and it occurs in sepsis and any other critical illness. So these markers will be there: coagulation parameters point plus low RBC plus thrombocytopenia plus schizocytes, shattered red blood cells on peripheral blood smear. So that is one possible cause of MAHA. Another cause is thrombotic thrombocytopenic purpura. So you realize that person begins to form useless clots, micro clots. What do you use to produce clot? Is your platelet. So the moment you utilize your platelet to produce tiny clots, you'll be using up all your heart platelets. Hence the name thrombocytopenic. However, you are forming clots, so thrombotic, but the clots are smaller, very tiny. So you are not going to block blood vessels. You are still utilizing your platelet. So it will get to a time where you get thrombocytopenia. And normally you will see of blood at times it appear like they are bleeding within or into their skin. Purpura. The full name hence being thrombocytopenic or thrombocytopenic purpura. Here again, you will see the general markers: low RBC, low platelet, schizocyte, together with infections, signs. So like fever, you may see AKI. You will have GPD and GCP going down. So you realize that the patients have some neuronal deficits. This normally comes when the patient presents with thrombocytopenic purpura. Or another example, another cause is hemolytic uremic syndrome. Hemolytic uremic syndrome. So this normally will come with infections such as our own Clostridium difficile infections. So you isolate C. difficile, issues like AKI will be detected together with the general markers for MAHA, low RBC, thrombocytopenia, schizocyte. Or HELP syndrome, those doing ONG as their electives. So you have high liver enzymes, low platelets, and hemolysis. So in HELP syndrome, it can cause microangiopathic hemolytic anemia. This is very common in pregnancy. That's why I mentioned ONG. You have elevated liver enzymes and what have you. And then unfortunately, cardio patients, those who have implanted artificial mechanical valves. So the artificial one, of course, can never be the same as the one created by the Almighty. So the artificial ones may be harder, too hard for these red cells. So as and when the red cells pass through the valves, they are stripped by these artificial ones. And that stripping is enough to break the red cell, is enough to shatter the red cell. So you realize that it will be causing hemolysis of the red cells because the artificial valve is too strong, very hard, and it strips the intact red blood cell, breaking them down with anemia occurring. Any of these critical issues can give rise to microangiopathic hemolytic anemias. And once it happens, you treat them accordingly. Apart from the MAHES, infections can also give rise to an extrinsic hemolytic anemias. Our own malaria can't be forgotten. So you have malaria parasites infecting the RBCs as per their life. They multiply in the red blood cells, burst. By way of bursting, that is hemolysis. So the red cell is gone. They come out numerous. Burst them. So with this continuous entry and bursting, continuous entry, proliferation, bursting, if you don't interfere with the life cycle with effective anti-malarials, you will end up having excessive hemolysis. That can lead to reduced RBCs. So this normally happens with hyperparasites. Levels of the parasite increases, then the levels of hemolysis also increases. This, when it happens, there is no problem with the red cell. It's just that an invader, an external factor like malaria parasite, is causing the hemolysis. Yet, it is still classified as hemolytic anemias.